My focus is going to really, in 15 minutes, talk about what is durability, what are the expectations, and where are we going. These are, actually, you know what, let me backspace one. Yeah, so this is the background. The problem is the data is really hard to truly interpret because definitions of durability thus far have not been standardized. And to really understand this, as Sushil pointed out, you need long-term follow-up. Both the low-risk studies now have mandated echocardiographic follow-up for 10 years, and that's sort of going to get us more information as we move forward. However, we've known, based on surgical history, that all bioprosthetic valves are not created equally. We've had mitral flows that were used in vogue for a while with a median life of 3.8 years before they failed. We had valves like the Toronto valve, which is a freestyle valve, and older valves like the Ionescu-Shelley valve, which all had very high midterm failure rates in spite of showing a lot of hemodynamic promise when they first came out. We do know that all current generation TAVR valves are made with similar materials as surgical valves and now are potentially going to be treated with similar type of anti-calcification treatments like the surgical valves have been. And another intriguing idea is this patient prosthetic mismatch, and that frequently mimics structural valve deterioration because both entities have high gradients and low effective orifice areas. And the last but not the least is that structural valve deterioration, although can be likened to be a binary 20 millimeter jump in gradient from a previously known echo, but it's really a continuous variable rather than just a categorical variable. So what we're really talking about is an intrinsic abnormality with deterioration of the leaflets or the supporting structures, either due to thickening, calcification, tearing, or disruption, which ultimately leads to hemodynamic dysfunction. These are some examples. On A and D, you see tears on the left ventricular and aortic side, respectively. On the right panel on the top, you see a heavily calcified magna ease. And then in panel C, you see a Medtronic engager valve with severe leaflet calcification and restriction. So again, so we all speak the same language here. What we're really talking about is bioprosthetic valve dysfunction, which can be divided into 4 categories. One can be the structural valve deterioration, which is what we're going to focus on. Then you have non-structural valve deterioration, either related to the valve moving, or due to patient prosthetic mismatch, or due to a paravalvular leak, which has nothing to do with structural valve deterioration. And then you have other problems like leaflet thrombosis and endocarditis, which are not the focus of our talk today. So we need to thank Danny DeVere for his work in this field to come up with some sort of a standardized definition and dividing them into stage 0, 1, 2, and 2R, 2RS, 2S, and then stage 3. I won't go into the details of the classification. Suffice to state that stage 2, the S stands for stenosis, R stands for regurgitation, RS stands for both regurg and stenosis. And stage 3 is when it gets really serious with gradients that are in the severe range for both either stenosis or regurgitation. These are the classic echocardiographic parameters. Of course, I won't bore you with the long and the short, but the bottom line I really want you to focus on is this need to re-emphasize the body surface area aspect of these effective orifice areas. And so a large man with a body surface area greater than 1.6 meters squared has numbers that are different than a little lady with a body surface area of less than 1.6. And that's something to consider when we look at and describe these entities. The other piece of the problem that is really not clear in the literature is the fact that surgical valves really had never been studied with the same degree of detail like we've done with our transcatheter valves. The most commonly reported measure of surgical valve durability is this term called freedom from structural valve deterioration. And what that really means is freedom from either severe AS or AR, or freedom from a repeat operation. Obviously, a lot of patients with severe disease may never have an operation or may have died before they got to the point where they were recognized to have this problem. So the issue is that this approach of freedom from structural valve deterioration clearly underestimates the real incidence of structural valve deterioration. However, we know that there are hypothetical reasons for reduced transcatheter heart valve durability. Some are related to the device, some are related to deployment of how we crimp these valves, and the other may be related to just the interaction between the device and the annulus, because unlike surgical valves, we are not really decalcifying the native leaflet, and there's opportunity for interaction that's unfavorable between the transcatheter heart valve and the native aortic annulus due to asymmetric expansion, as Sushil demonstrated earlier, the stent tip deflection that he was talking about, all of which can lead to potentially concerns about reduced durability. This is again a slide that he showed where you had accelerated fatigue and high stress demonstrated at asymmetric points on the valve leaflets, as demonstrated by Martin and Son in their Journal of Biomechanical Engineering. Again, this is elastin fragmentation and an uncrimped control, and here you have the disarray of elastin. Can you see very clearly after you've crimped these valves? This is a slide that Sushil demonstrated earlier that looked at this whole entity that was first described by Carlos Ruiz and reported by Raj Makar as part of the Portico study, and then since been duplicated in most other valves, where you have an incidence that we're not really sure what the incidence of it is, but roughly in the 5 to 10% range, with some association with neurologic events. As you can see, this reduced leaflet motion is seen with all types of valves, both transcatheter as well as surgical valves. It's usually picked up on a 4D CT, and anticoagulation was associated with resolution of this thrombus in the majority of the patients, as can be shown very nicely in the images on the right. So do these hypothetical concerns clinically make a difference is a real question. And this is another slide that Sushil demonstrated, that TAVI and surgery essentially have similar safety and freedom from long-term outcomes, barring the earlier risk for stroke, bleeding, AFib, and acute kidney injury from surgery. But overall, the outcomes from a time to event analysis are essentially the same. Similarly, when you look at PARTNER 5-year data, looking at the cohort A patients, again, there really wasn't any structural valve deterioration that required re-intervention out to 5 years, with mean gradients demonstrating a nice decline and staying low in that 10 to 20 millimeter range. Similarly, the valve areas didn't show any decrement and increased from 0.6 at baseline to roughly in the 1.5 to 1.8 range, and we didn't lose any ground over a 5-year period on follow-up in the PARTNER trial. The supraannular SIR-TAVI data from the core valve, you see similarly better valve performance than even the surgical valves, with valve areas in the 2.1 range and gradients in the below the 10 range. We also know that TAVR is clearly associated with less of patient prosthetic mismatch than surgical AVR, and this was demonstrated both in the PARTNER studies as well as by Zorn et al. In the core valve high-risk pivotal study. So since Alain Cribier did the first transcatheter heart valve in 2002, we've come 16 years. His site in Rouen, France, looked at the assessment of structural valve deterioration in balloon expandable valves using the new European consensus document that just came out. And they found that over time, in their experience, which is a single center experience of several patients up to 8 years, there was similar increments in both mean gradient and aortic valve area as seen in the PARTNER and the core valve studies. And the patients and a lot of the patients had in excess of 90% freedom from structural valve deterioration out to 8 years. However, the patients that did show structural valve deterioration had one common feature. They all have patients with renal failure, just similar to the data you would see with surgical valves. Similar to what has been known in clinical practice, in the VIVID registry, Danny DeVere very elegantly demonstrated that surgical valves also have had a median time to requiring reintervention for TAVR with a median time of only 10 years with a clear bell-shaped curve. And similar to what I said earlier, some of these valves deteriorated much earlier and the others sort of had a much longer time to failure. So in summary, what would be a clinical approach to structural valve deterioration in 2018? I think stage 0, 1, and 2 warrant close follow-up and repeat echocardiography, especially once you start getting into stage 2 with mixed disease, and stage 3 is when you really start considering reintervention, especially in patients who have symptoms. This is data from the STS ACC TVT registry, which looked at the multivariate logistic regression model of what the potential predictors might be for hemodynamic deterioration. And what we found was that male patients with larger body surface areas that underwent TAVR with small valves, or who had valve-in-valve implantations, or who had patient-prosthetic mismatch, were at risk for potentially developing structural valve deterioration sooner than others. So what would be our take-home message? My take-home message from this talk would be that bioprosthetic tissue valves, whether they're surgical or TAVR valves, are both associated with valve deterioration. Most implanted tissue valves can be treated with a less invasive approach, most commonly a valve-in-valve, of course, with the caveat that outcomes in smaller sized valve-in-valves are much different than the larger sized valves. Intermediate and high-risk older patients, like they have been in the United States, should be safely and effectively treated with TAVR. However, in the low-risk patients and younger patients, and especially in those with some of the things that Sushil talked about, like bicuspids, etc., should be not treated until we have better data, awaiting the results of P3 and the low-risk core valve study, which we should have within the next year. Until then, surgery would still remain the gold standard. Thanks for your attention.